Recording in progress.
There are three hormones produced by the adrenal glands. They are aldosterone, cortisol, and androgens. This is true in the female patient. In the male, there are only two hormones, namely the aldosterone and cortisol. The sex hormones in the male comes from the testicles. So problems arising from adrenal problems is either another endocrine problem. So it's either you have too much of these hormones or not enough. So commonly they are called the salt, sugar, and sex hormones. Salt hormone obviously refers to the aldosterone, and then the sugar hormone is the cortisol, and then of course the sex hormones. The sex hormone deficiency or excess isn't really life-threatening. However, the salt and sugar hormone excess or deficiency is life-threatening. Now, remember that there are two parts of the adrenal glands, the medulla and the cortex. For purposes of today's discussion, we're only focusing on problems affecting the adrenal cortex. Okay, we'll come back to the medulla another time. So cortex is where the salt and sugar hormones are coming from. Aldosterone and cortisol come from the cortex. The medulla produces the catecholamines, namely epinephrine and norepinephrine. Function-wise, glucocorticoids or cortisol obviously raises blood sugar. So this is secreted in periods, during periods of stress, during periods of illness, trauma, surgery, etc. And for mineralocorticoids, this is the trigger. If you remember from fluid and electrolytes, aldosterone is part of the renin-angiotensin-aldosterone system, which is triggered whenever there is low sugar, low salt, low blood pressure, low blood volume, low oxygen. And like I said, the sex hormones, the androgens, only affect the female patients because the male androgens come from the testicles. But again, this is not life-threatening. However, is it important to the patient? Yes. First problem is pheochromocytoma. This is really short because this is a tumor. This tumor is growing from the adrenal medulla. So therefore, if you have a tumor growing on the adrenal medulla part, which produces what hormones again? What hormones are secreted by the medulla, adrenal medulla? Epinephrine and norepinephrine. So if there's a tumor secreting these hormones, what will the patient look like? Really high epinephrine, norepinephrine. So what will you look like? Okay, so a very, like a chicken, okay? So the patient will be very hyperactive, short attention span, okay? Very nervous, shaky, okay? High blood pressure, high heart rate. And what will happen to the, what could happen to the patient? Die of what? Die of what? What could kill the patient?
The heart rate, the blood pressure.
And they have a stroke?
Yeah.
A heart attack?
Yeah.
All right. So here are the manifestations. I won't read the whole thing. Again, think of somebody who's in fight or flight constantly. And the symptoms, of course, of hypertension, because these patients will have severe hypertension, will be the headache. Right here, see the headache, vertigo, blurring of vision, tinnitus. These are all manifestations of severe hypertension. And consequences of severe hypertension, of course, as mentioned, will be aneurysm, stroke, and this can cause kidney damage as well. So I already described the manifestations. I won't have any questions on the testing because again, there's no role. The doctor will prescribe blood work, checking levels of catecholamines, and they will also require a CAT scan or MRI to locate or to confirm the presence of the tumor. Because it's caused by a tumor, what do you think is the management? Surgical removal. Okay. Because the tumor likely is bigger than the adrenal medulla, so the patient will lose both the adrenal gland and the tumor together. If the patient is not a candidate for surgery, then it will be managed with medications. Medications will be, what do you think, to manage severe hypertension, severe sympathetic stimulation? A beta blockers, calcium channel blockers, ACE inhibitors, so many vasodilators, so many medications will be used, diuretics, in order to manage blood pressure until the patient undergoes surgery. The preferred treatment, of course, because can we just manage the tumor and the symptoms with medications forever? No, it has to be removed. So until such time, patient will be managed pharmacologically until they are primed for surgery. So once ready for surgery, the patient will lose one or both adrenal glands, depending on how many are affected. We anticipate a hypertensive crisis because is surgery a stressful event?
Yes.
Will it trigger an attack? Yes. All right. Now, if the patient loses both adrenal glands, what will happen to all the hormones secreted by the adrenal glands? They're gone. So therefore, how can the patient survive now? Okay, so for how long? Okay, so lifelong hormone replacement in the form of hydrocortisone will be the therapy. So the corticosteroids they're mentioning here is hydrocortisone. The benefit of hydrocortisone is it has the effect of not just glucocorticoids, but the same effect of mineralocorticoids at high doses. So the patient will be receiving high doses of hydrocortisone for life, and that will manage both blood sugar and blood pressure at the same time. We will talk about the consequences of this therapy once we get to Cushing syndrome, which is another section of this chapter. Now, what if the patient only lost one adrenal gland?
Then maybe the other one will make up.
Okay, so it will still require hormone replacement, but not for life. Okay, maybe a couple years until the remaining gland makes up or compensates for the loss of the other one. Any question? That's about it. We'll deal more with the consequences of long-term steroid use under Cushing's. Okay, it's not discussed here. Let's go to the next problem, Addison's disease. So same adrenal gland, but this time it's a deficiency. The patient doesn't have enough aldosterone, not enough cortisol. Now let's look at the cause first. Well, there's two possible causes here. Most common is a tumor. Now, since there are two endocrine glands involved, it's not just the adrenal glands, because what is the master gland? The master endocrine gland. Pituitary, right? Okay, all right. So therefore, the pituitary controls the adrenal glands. So where could the tumors grow? Only in the adrenal gland? It could also be from a pituitary tumor. Okay. So two possible sources of tumor. So therefore, causes of this that leads to Addison's disease is an adenoma. So the adenoma can be in the pituitary, a pituitary adenoma, or a adrenal adenoma. This time, where is the adenoma growing? On the cortex or on the adrenal medulla? The cortex this time. Okay. Or it may not be caused by a tumor at all. A small percentage of people who have primary adrenal insufficiency, that's what we call Addison's disease. If it's caused by a tumor, then we call it adrenal insufficiency. Simply, or second, you can call it secondary adrenal insufficiency. But the manifestations are exactly the same. Because since the patient in both cases, primary or secondary, both have low levels of aldosterone and cortisol. Okay. So what's the purpose of aldosterone? How?
Yeah.
Okay, so it causes your body to reabsorb sodium and water. Okay, so in what cases is this needed? When does our body normally secrete aldosterone? During periods of low blood pressure, low blood volume, all right? Low oxygen, right? You know, renin-angiotensin aldosterone system. Okay. Sympathetic system is separate. Okay, that's a separate reaction. So if this is the case, and then cortisol, what's the function of cortisol?
Stress.
It's a stress hormone. So by the term itself, it is secreted during periods of stress, which can be anything, right? Stress is subjective. So we need that in order to survive stressful events, to react and then continue to function. So imagine a condition wherein both hormones are low. So what happens to the sodium level?
It's low. The blood pressure.
Okay, let's start with deficiency. This is Addison's or secondary adrenal insufficiency. So the aldosterone, the salt hormone, is low. The cortisol or the sugar hormone is low. So what happens to the patient's sodium level? It'll be low. What happens to blood volume? Low. What happens to blood pressure? Okay. Because sodium is sodium able to be reabsorbed by the kidneys
Yes.
without aldosterone?
No.
No. So therefore, sodium is lost, correct?
Yeah.
What is the relationship between sodium and potassium? Okay. So therefore, without aldosterone, sodium is lost, potassium is reabsorbed. So the patient now has a hyperkalemia and hyponatremia. Okay. So let's pause there. Let's go to the cortisol side. So cortisol is low. So what happens to glucose? Drops. So that's the third problem here. So the patient also has hypoglycemia. Now choose which one can kill the patient. Hypotension, hypoglycemia, or hyperkalemia. So the other two will not kill the patient. So I'm asking you again, which one will kill the patient? All three, okay? Any of those three can kill the patient by itself. So is this a dangerous condition? Right. We'll talk about the crisis shortly. So we describe the manifestations, and the manifestations here are related to the electrolyte imbalances. So these manifestations reflect hyponatremia, hyperkalemia, and hypotension, and hypoglycemia as well. Now, there's a life-threatening condition because you can live with Addison's disease or secondary adrenal insufficiency with the help of hormones. However, these patients can have crisis events. So call these acute exacerbations, and this is triggered by stress. The most common examples of stress that will trigger a crisis is illness, like sepsis, for instance, severe illness, trauma, any trauma. It could be surgery, it could be a surgical procedure, or it could be any other trauma, okay? Or any psychological or emotional or physical stressor. Okay, so those are the triggers. Now, as I described, there are three possible causes of death during a crisis. They will be severe hypotension, just like shock, and there will be, of course, severe hypoglycemia and severe hyperkalemia. This is what happens during a crisis. So you develop the crisis if you already have Addison's disease or secondary adrenal insufficiency. You follow so far?
Yes.
So these patients are taken, they're kept alive because we give them hormones every day, hydrocortisone for life. However, the doses need to be adjusted because during these periods of stressors, I mentioned surgery, infection, or trauma, what happens to the requirements by the body? So therefore, their everyday steroid dose, is that enough? No. Even with slight overexertion, exposure to cold, so these are the other triggers for Addisonian crisis, can be precipitating the event. And then the patient could die unless they are hospitalized immediately. Now, what other examples could you use here? So let's say in pharmacology, you studied steroids, right? There was a chapter wherein you talked about corticosteroids, glucocorticoids. So what were you taught to teach your patient? So if they're taking long-term steroids, what must they never do?
Just abruptly stop it.
Never abruptly stop the, right. So what was the reason given to you in pharmacology? Why can't we stop steroids abruptly? What was the reason given to you? Here is the reason, okay? So the patient will go into an Addisonian crisis. So one of the causes here is sudden cessation of long-term steroid therapy. Now, can this happen when a patient's hospitalized, for instance? Let's say I'm on long-term steroids. I'm hospitalized because I'm so sick. If I'm so sick, can I take my steroids still?
Yes.
I can't even swallow. Okay, I'm unconscious. Okay, so therefore, these patients must never stop the steroids. So therefore, in any illness condition wherein they cannot physically take their oral steroids, what should you advise the patient or the family to do? Admit them to the hospital. They must continue receiving these steroids. So what if the patient's NPO for surgery? What are we going to do? Okay, the patient continues to receive steroids even if they're NPO. Yes, they will die. They will go into Addisonian crisis. So management, let's manage the crisis first, okay? Because this is because the Addison's disease, the everyday long-term condition, is managed simply with steroids every day. Here in a crisis, however, since the causes of death are shock, severe hyperkalemia, and severe hypoglycemia, patient has to be hospitalized. So there are three competing conditions here, because can you choose between the three which one to address first? No, each one is capable of killing the patient independently. So all three must be managed at the same time. So can one nurse handle this patient?
No, I see.
Okay, so this patient's either managed in the ER or in the ICU. Okay, so a whole team, when we discover a crisis, then it's a rapid response condition situation, and then the patient will be managed accordingly. So let's start with one. First is shock. So how do we manage the blood pressure part?
Fluid.
Okay, so they'll be given lots of fluids. Look at the choices here. First is hydrocortisone IV, followed by 3 to 4 liters of D5, which is isotonic, correct? And then followed by vasopressors in that order. And then this hydrocortisone mentioned here is just one dose. However, there will be a continuous infusion. Okay, so they'll receive a hydrocortisone infusion plus boluses usually every 12 hours. Usually intramuscularly.
Of the hydrocortisone?
The same hydrocortisone. Antibiotics is mentioned here because what is the most common cause of a crisis? Usually the patient got sick. Yeah, they're septic, so we treat the underlying trigger, which is again, usually the patient got sick. That's why their hormone doses aren't enough all of a sudden. And then if it's not illness, then the doctor has to identify, the team has to identify what triggered the crisis. Okay, it could be as simple as me and Tahina, for instance, just having a fight. Hey, she said she won't see me anymore. And then that was my trigger. Okay. Let's go to the second one. So that's the management for the hypovolemia, the hypotension. What about for the hypoglycemia? What do you remember? What's the options? What are the options to manage hypoglycemia? Glucagon, IM or IV. What else?
The sugar.
Dextrose. Okay, 50% dextrose. What else?
Insulin? I mean.
No, sorry.
We'll get to that later.
Like
Calories, increased calories.
We can also give, well, hydrocortisone can also do that. Right.
The hydrocortisone?
So the 5% dextrose here, that's why this is the choice versus saline or LR because they don't contain dextrose. So that's why this isotonic solution here is kind of two. Okay, right. Double acting, double-edged sword because you're increasing blood volume plus increasing glucose at the same time.
This is 3 to 4 liters of normal saline or dextrose.
Yeah, so between them, what would be your better choice?
Because you're hypoglycemic.
Oh,
Exactly.
okay.
And then, so that takes care of our hypoglycemia and hypotension. Now let's go to the hyperkalemia. So remember last semester, what were the, give me 4 choices to drop potassium. First, okay, so we got diuretics. We have
Insulin.
SPS, sodium cholesterol sulfonate, and then insulin with dextrose. Okay. Not suppository, you mean an enema.
Yeah.
Okay. So SPS, since this patient, is this patient conscious? Is this patient conscious? Hypoglycemia, hypotension, no, this patient's unconscious. So the SPS will be given by a enema. Okay, they can't swallow anything. These patients are intubated. Okay. And then of course the insulin with dextrose. Okay, solution. And what else? Calcium gluconate, right? Okay. And that's it. Hopefully the patient survives. And then we go on to managing them day to day. So we calcium gluconate for hyperkalemia. Sorry.
Because it's because of the hyper.
And it will work to for the hyperglycemia as well. The gluconate part.
No.
No.
It's a different.
No, it's not glucose now. All right, that's about it. And let's go to the discharge part for the patient. The steroid dose will be mentioned under Cushing's because I know it's ironic, but that's where it's located. So it's not mentioned here, the dosing and the instructions on how to take the steroids. Okay. All right, so I won't read the whole thing. Now, I'll like to stress on compliance. So these patients must understand that the steroids are for life. There is a need for less or more dosing.
How often they have to check?
Yeah, so is regarding this bullet point here is what happens to the steroid doses during periods of illness or stress?
You have to increase it.
Okay, so the patient is taught how to do this. However, if they're not sure, they have to consult with a physician and they will be told by how much to increase. What if they're too sick and can't take anything by mouth? Either that or a family member can be taught to administer hydrocortisone IM,
Oh,
okay, in cases of emergency. So let's say I'm just having a moment, again, with Tahina. I just can't, cope with not seeing her. So my mom would give me,
The IM injection.
yeah, the IM injection. Okay, and then call her and then say, hey, come back. And here, medic alert. Of course,
Right?
I mean, these are practical. So please read again the the diet, okay, especially during periods of illness. All right. There's a drug table. Again, it's not in this section. We'll get to it under
They're both
Cushing's.
taking same drug? or what?
Yeah. I'll explain why later. Any questions? So this is the life of an Addison's patient. All right. Let's go to Cushing's. There are two terms here. Let's distinguish between Cushing's disease and Cushing's syndrome. Manifestations are the same. The cause is different. Let's start with Cushing's disease. This is usually caused by a tumor again. So remember the tumor earlier, pheochromocytoma, and then the tumor, the adenoma, causing Addison's disease, a tumor in the pituitary gland, and then a tumor in the adrenal glands. Okay, so this is the same adenoma. If that is the one causing the excess hormone production, meaning it's what's causing the high levels of aldosterone, high levels of glucocorticoids, we call it Cushing's disease.
That's the disease.
Right, because where did the steroid come from? From a pill bottle or from the patient's own body? This is the patient's own body causing it. That's why we call it Cushing's disease. Okay, so therefore, what's the treatment for disease? Cushing's disease. Because what's causing it? A tumor. Okay, so therefore, we remove the tumor. So therefore, if that's the case, Cushing's disease, and this is what the patient looks like.
Oh.
That's Cushing's disease. That's just the upper part. Okay, we have to look at the lower part. If you're interested here. Cushing's disease, Cushing's syndrome will be the same. Manifestations wise. So this is what they look like. Okay. So that's a female Cushing's disease or Cushing's syndrome patient. That's what you will look like. Now imagine having high aldosterone, high cortisol all the time. What will happen to your sodium level?
It'll be high.
Your blood volume,
High.
your
High blood.
heart workload will be, will you have heart failure?
Yeah.
Your sugar level,
Really high.
and what will your body do with excess sugar? Turn it into, okay, so the fat deposits will be here in your face, on your neck, on the back of your neck, on the trunk mostly, in your thighs. And because you have high sodium, so are you retaining water? You have high sodium, you are retaining water? Yes, so you'll have edema all over from head to toe. These stretch marks here appear because the increase in the abdominal girth is not gradual. It is quite fast. This is not the same as obesity, wherein the obese patient takes years in order to develop, to gain this weight. This develops within a few weeks to several months. So not enough time for the skin to adjust. So there will be several striae appearing. The skin will be very thin, prone to injury. And because of this now, you have more fat than muscle. What will happen to muscles? There'll be some muscle wasting. And then because of that weight on your skeletal system, what will happen?
Easily fractured.
Okay, so there will be, but plus what happens to your acid levels here, gastric acid levels? Increases, okay. Because these are your high in stress hormones, so you'll have peptic ulcers, correct? All right, and then there's osteoporosis here. Are you prone to fractures as well? Okay, easy bruising. Okay. And what did we learn also in pharmacology? When you have high steroid levels, what happens to your immunity?
It decreases.
So these are just for the aldosterone and cortisol. Now, this is a female patient. So if we add any changes to the sex hormones here, what happens to the patient's reproductive function? Amenorrhea. And will she still have the same libido? No more. And what about ovulation here? Is it predictable? Besides, do you want to get pregnant during this scenario? Okay, probably not the best time. Okay, so here is all the problems here listed. It's also on your textbook. Here under your, sorry? Yes, they also have hair in parts where you don't want to have hair. So here are your manifestations, chart 4512. So this one displays the manifestation system by system, which we discussed already. So there you have acne. So even if you're in your 50s, you still have the breakouts now because of the high sugar. Okay, this is the problem. Okay, so let's go to management of Cushing's disease. So we said this is caused by a tumor, correct? There is a pharmacologic management here, but it's not really used long term. These are the drugs used. If the patient cannot have surgery yet, these are the drugs that will be used in order to control the hormone levels. However, I'm not testing it because you won't see patients with Cushing's disease on it for months. They will only have it for a few weeks, temporary, because what's the main treatment?
Surgery.
Is surgical removal of the tumor, the one causing the increased salt and sugar hormone production. Now, think about this. Since there are two possible sources of the tumor, so we discussed adrenalectomy already under the previous slide, and previous page under pheochromocytoma, right? And also again here we won't discuss, it'll be the same, right? But let's look at the preparation first. So let's go to surgical preparation. Maybe here, and we skipped it. Okay, now this is important. Right here in the, I went back to pheochromocytoma, just under the surgical part, because I forgot to discuss this. Now, remember that this is now a Cushing's disease patient, all right? What's their aldosterone and cortisol levels? Very high. Now, when we surgically remove it, is the production of the aldosterone and cortisol stopped once we remove the tumor and the adrenal gland? Yes.
Yeah, that's why they have to
Yes,
take
it
the
stops.
back.
However,
Because you cut
how
out
did
the-
it stop? Did it stop slowly or suddenly the moment you took out the gland? So what can happen during the surgery? They will die from a crisis. So therefore, how do we prepare the patient before the surgery? Okay, so we will now start suppressing the patient's adrenal gland by giving them exogenous steroids. So we start giving them hydrocortisone before surgery. That way it will start suppressing endogenous production, because once you give them hormones, that will be a inhibiting trigger, right? Yeah, so your own production will stop because you're taking hormones, right? So we start giving it, and then we schedule the surgery. So it's about 2 weeks, okay, before surgery. We give them steroids, and then on the day of surgery, do we stop the steroids?
No, they get a dose
No,
right
it
away.
continues. During surgery, they get an infusion. Okay, they get an infusion. Remember, because we're NPO. So patient gets continuous infusion of steroids. We cut the sucker, we cut it out. So do we have a crisis? Do we allow a crisis to happen? No, because we're giving them a steady infusion of steroids. And then of course, after surgery, how long is the
They get one and it gets tapered down. But it's for life.
yeah, so do we taper?
No.
No, this is for
No,
life,
no.
because unless it's only one adrenal gland
Oh, not both.
removed, right?
Okay.
But both, it'll be
For life.
forever. Okay. So that's management for Cushing's disease. Now, what about if the tumor is in the pituitary gland?
Remove there,
Remove
Okay. What's the size of the pituitary gland?
small.
Very tiny.
What's the size?
The walnut.
I know it's small.
Okay, so I went back to pituitary tumors, the same chapter. But earlier, let's go to management. Okay, so here, this is under pituitary disorders. See how Cushing's disease is mentioned here?
Yeah. Where did
This is page 1451. This is under pituitary disorders. Okay, under surgical management. So the number one cause for your pituitary gland to be removed is a Cushing's disease. So if the tumor is growing from the pituitary gland causing Cushing's disease, of course, the pituitary gland has to be removed. The procedure is called hypophysectomy. Okay. Now, where is the pituitary gland located? Where exactly?
Wait a minute. Is it in the?
Right here, between your eyes. Okay? So therefore, where's the best surgical approach? Since it's right behind your eye, between your eyes, right somewhere here.
From the eye?
Here.
From the nose?
Okay, so is it practical to
No, no.
crack your skull open? No.
So how would they do?
So they do it either a transfrontal, but the most common procedure or approach is transphenoidal. This is through your nose.
No.
So they'll remove your sphenoid bone, cut an opening, insert the instruments through. Don't worry, you're intubated here, you're unconscious. And then they remove the tumor through here. Because which one is bigger here, the tumor or the pituitary gland?
The tumor.
Which one's bigger?
The tumor.
The tumor. The pituitary gland is a pea-sized gland. So of course the tumor is bigger. Can you peel a big tumor off of the tiny pea-sized gland? No. You're gonna end up losing the pituitary gland. Because you lost it, then we'll replace whatever hormones are produced by your pituitary gland for life, right? So here's your role here. The questions on the test will be pre and post surgery care. Pre-surgery, nothing much, because this is pituitary gland removal. This is hypophysectomy, not the adrenal gland, so it won't affect the steroids. So no steroids necessary here. You will receive instructions though, because you manipulated the organ through the nose. What will happen post-op?
Drainage.
Bleeding through the nose. So there will be packing. So expect tight packing through both nostrils. And therefore, can you breathe?
No.
How will you breathe?
Not
Through your mouth. Okay. Another warning is you cannot brush your teeth, because besides the instruments through your nose, they will make a small incision at the roof of your mouth in order to reach the gland. Okay, so there'll be an incision at the roof of your mouth, which is prone to injury when you brush your teeth, correct? So therefore, can't brush your teeth until your doctor tells you, usually a few days.
Oh, God.
Until then, you just use mouth rinses. You can floss your teeth, no problem with that. Can you?
Would they still be impure?
No, you can eat. That's fine. However, the problem is, can you sneeze?
No,
Yeah.
the pressure.
Can you cough?
No.
Can you bend down?
Yeah, how do you stop it? This way?
They give you something to.
How do you stop the sneezing?
They give you something to
Antihistamines.
suppress the cough.
Oh, okay, you did it.
Can you bend down to tie your shoelaces?
No.
Can you have sex?
No.
Like intercourse?
No.
No. Can you
Pressure.
give birth to a big turd?
No.
No.
How long is the recovery?
About a couple weeks.
2 to 4 weeks. Depending on the healing. I want the recovery quickly. Those are the test, right?
Page 2016. So post-op, could be a CSF leak. Now, the drainage, so let's talk about the packing. So we put a packing here, and there'll be a drip pad called a mustache dressing. What's it gonna look like? The drainage.
What?
Is it gonna be clear, bloody?
Bloody.
Bloody, okay? So it's gonna be bloody. So there's a tendency that there will be a CSF leak. So if there's a leak, how do you know that it's CSF?
You test it for glucose? Yeah.
The problem with that option is when you
Okay,
test
you
it for
can't just do it.
glucose, it's bloody. So therefore, does blood contain glucose?
Yeah.
It's always gonna be positive, okay?
Okay. Makes sense.
Because it's bloody. So therefore, what's the better way to check for CSF? How do we check for a halo sign?
Don't you like dye it
Paper or
something?
gauze?
And dab it.
So
Don't you dye
you
it?
gotta gauze and dab it.
Okay, so you're gonna put a piece of gauze onto the bloody drainage, dab it, and if you see a yellow ring around the bloody drainage,
Yeah.
that is CSF. Are we clear?
Yeah.
Okay, so that looks primitive, right? But it's the most effective way. Again, we do not use the dextrose test because why? It's always gonna be positive for glucose because it's bloody. Where was I?
You know.
And I already talked about the prohibited
The what?
activities, right? So no sneezing,
Yes,
no
yes.
coughing. Okay, no bending down, no intercourse.
So if you see the halo, what do you do?
Report it to the physician.
Question, are you looking at the shape or just the front?
The color. Yeah, it'll be a ring.
So it is in the shape of the circle.
Yes, a yellow ring
So what does that
So
mean
it's
for the,
around the
and
blood.
color?
what does that mean for the patient when you see
Make
that?
them-
There's a leak. So that usually the doctor won't do anything. They'll just put the patient on bed rest. But if it continues, they'll probably go back in and fix the leak, which is rare. Where was I again? Oh,
So we have to read this trans in order to.
yeah, just the post-op part. Okay, let's go back to Cushing's.
1474.
So that was for Cushing's disease. So let's go now to Cushing's syndrome.
Treatment 1470.
Okay. So what's the treatment for disease again?
Surgery.
Surgery. Okay, so two possible surgeries, hypophysectomy or adrenalectomy, unilateral or bilateral. Now let's go to syndrome. It's called syndrome if the source of the steroids, the high steroids, is not the patient's body, but exogenous, meaning treatment for Addison's disease, treatment for asthma, treatment for Crohn's, or whatever is the reason that you're taking steroids for, okay? So if you develop the manifestations I showed you earlier, these here, if you develop this condition, because you're taking exogenous steroids for life or for a long time, then it's called Cushing's disease. Because does it need surgery? No. What's the only treatment for this condition? Can we afford to stop the steroids though?
No.
Kind of
Taper?
tighter.
Because what's causing this? Is it because the steroid was accurate, was adequate, or too much?
Too much.
The patient ended up too much, right? So it's not that easy to do though, but it can be done. So the doctor and the patient will agree on a plan on how to decrease the dosage that still meets the patient's needs without causing a crisis, right? So this is what I mean by it's easier said than done. It's not easy to come to a exact dose because from day to day, from season to season, will your needs be the same?
No.
No. Okay, so you change girlfriend, you change boyfriend, will your requirements, hormone requirements stay the same? No, you go from one semester to the next semester. Will it be the same?
It should.
No, it will be different. Okay?
Girl.
So manifestations as already laid out in the chart. So again, for Cushing's disease or Cushing syndrome, exactly the same. Treatment will be night and day. It was surgery for Cushing's disease. It is dose adjustment for Cushing syndrome. Okay.
That's better.
All right. Now, what have you noticed here? So let's go back to the Addison's disease patient. Or let's say, let's talk about Cushing's disease. So the patient had a tumor and then they looked like this, right? When they had Cushing's disease. Okay. And then you told them, or the doctor told them, okay, well, we found out what's wrong. You have a tumor in your pituitary gland or in the adrenal gland. We're going to take it out. Oh, and the patient said, okay, and doctor will say, hold on. After the surgery, you're going to be placed on hormones for life. There's a chance you could develop Cushing's syndrome.
Oh, that's when they monitor the.
So the patient will go,
level.
wait a minute. I have Cushing's disease, and you're telling me you're going to manage this with surgery, and then you're going to give me hormones for life, which will put me back in the same exact spot. The doctor will say, no, this is not disease anymore. This is now syndrome. What the? But the patient will still look the same. You see what I'm going with this?
Yeah.
So it's make sure the patient is supported, okay, that they understand the predicament that they're in. Okay, so there's a possibility that yes, they started with disease, but they may end up with syndrome. But at least the syndrome, can it be managed?
Yes.
Easy?
No.
Not that easy, but it's possible. Correct. All right.
So.
Taking the medication? Or not?
Adjusting the dose.
adjusting the dose.
Yeah, because they have no choice. They have to take the
So when you start
medication.
gaining weight, you have to.
yeah, get the blood test and then adjust the dose, and then your appearance will improve. All right.
That's why they tell patients with
So-
like asthma to monitor your AC and
The
TH levels or
ATTH,
something
yeah.
like that.
Mhm.
Okay.
So all the manifestations I mentioned here from the from the buffalo hump to the striae to the osteoporosis, the peptic ulcer, they're all here. Okay, and in this chart here,
Oh, wait.
and like I said, the management, of course, is to adjust the dosing. However, while they're in a Cushing syndrome condition, do we not manage the osteoporosis?
Yes.
Yeah.
We still manage that. Do we not manage the peptic ulcer?
We do.
We
Yes.
do. Do we not manage the hyperglycemia?
Mhm.
Do we not manage the the osteoporosis?
Yes.
I already said that, right?
Yeah.
Yeah. Do we not manage the heart failure,
Yes.
the edema,
Definitely.
okay, the risk for fractures, the so everything will still be managed.
Yeah.
Okay, so it's not just simply adjusting the steroid dose because they already developed the osteoporosis, the hyperglycemia,
So
the
it's got to
peptic
be
ulcer.
treated.
Right. All right. So you protect the skin also. That's part of your nursing care. So it's a complicated treatment. And if you're dealing with that, how much more, as a nurse, how much more do you think the patient feels? Right. So here they develop diabetes, peptic ulcer. All right. So which one do you want?
Neither one.
Addison's or Cushing's?
Not him, right?
So here are the nursing care plan. The
You know, some people die.
because they can develop heart failure here, okay, because of the massive fluid overload that can result. So they can have heart failure and then the pulmonary edema that follows. Here, the injury is not just for falls and the fracture, but also the skin tears. Remember, the skin is very thin. So you grab them like normal people, they can tear easily. Protect them from infections, which is a challenge. Let's say this patient had Cushing's disease. They already look like this, correct?
Mhm.
And then after surgery, since they develop Addison's, correct?
Yeah.
Yeah. And then we put them on steroids again for life.
Mhm.
What will happen to the healing after surgery?
It'll be delayed.
Exactly. So that's another complication that will result during surgical management. Okay. So it's not that easy. Here, improving body image. Again, this is done through dose adjustment of your patient's steroid medications. They're coping. This would be your best option. It just help them cope with the condition. Then again, educate them about Addisonian crisis, right? What's the trigger again? So you have a Cushing's syndrome patient taking it. No, they have Addison's and then they develop Cushing syndrome from the hormone replacement.
Not fun.
All right. Now let's go to the teaching. Let's go to the hormone replacement. So let me finish. So with the hormone replacement, what should your teaching be? When should they take the hormone?
In the morning?
The morning is correct. What if it's twice a day? When should the second dose be taken?
Midday.
Right?
Evening. Okay, early evening. Why not at bedtime?
Because they're sleeping,
It's a steroid, so it will give them a lot of energy at bedtime. Will they sleep?
Having fun.
This causes peptic ulcers. They have hyperacidity. So when they take it on an empty stomach,
No.
with food, always with food. Okay, steroids should be given with food. What do they do again if they get so sick? Because they will get sick, correct?
Increase the
Yeah, there will be a time they will get sick eventually because of the immunosuppression. So what do they do if they can no longer take the pills or go to the ER? Yes, Mr. Thomas?
Complication of treating Addison disease is Cushing's syndrome.
Because of the lifelong hormone replacement or the long-term hormone replacement. Can't win, right? All right, let's finish up. This is very short. Primary aldosteronism, another tumor causing an increase of aldosterone. This is the only hormone involved though, unlike in Cushing's where it's both aldosterone and cortisol. This one only aldosterone. However, treatment will be still surgery until the patient gets surgery. You have to manage the symptoms. What would be symptoms here? The patient has high, severe hypertension. Can they have a heart attack? Stroke? Okay, fluid overload. And potassium will be?
Low.
Potassium will be low. So here are your manifestations. They all related to hypernatremia and hypokalemia.
Okay, I went to the other, I thought that was the other side.
Okay, so here's the hypokalemia, the hypernatremia, which is manifested in the blood pressure and the blood volume.
Okay, that's.
Medical management, blood pressure medications, potassium replacement, and then what's the main treatment? Surgery, just like pheochromocytoma. So why give spironolactone?
Potassium.
Okay, it's very good because this will raise the patient's potassium while dropping the blood volume and blood pressure. So here are the steroids. Most commonly, you'll deal with Solucortef, which is hydrocortisone. Okay, so it's all in one. It has the benefit of both glucocorticoid and mineralocorticoids. So with steroid therapy, what are side effects again? So everything you see in Cushing syndrome, all those manifestations, the hypertension, the immunosuppression, hypoglycemia. What's the purpose of tapering again?
Crisis.
Okay, to prevent Addisonian crisis. Another term for that is the doctor may not use Addisonian crisis because really when we say Addisonian crisis, we're referring to someone who has Addison's disease. However, these patients, not all patients taking steroids have Addison's. Okay, so it could be another reason. So the term for those patients will be acute adrenal crisis. Clear? But if it's Addison's, of course, we call it Addisonian crisis. If they don't have Addison's but taking steroids, then it'll be acute adrenal crisis. So here are your side effects, table 45.3. For hydrocortisone or whatever, prednisone, beclomethasone, whatever steroid is used, same side effects. So hypertension, DVT, risk will rise. Okay, so here's the immunosuppression, glaucoma, here's the muscle wasting, fat deposits, osteoporosis. This is all long-term, all right? We're not talking about short-term here. This will not happen if it's just, let's say, 2 weeks of steroids, right? Let's say you're given the Medrol dose pack. Let's say you have pneumonia or asthma, you're given the Medrol dose pack, right? They won't result in Cushing's, okay? Because that's a couple weeks only. That's it.